Reoperative Intervention and Surgery for Multifocal Lung Cancer by Shanda Blackmon, Professor of Surgery, Mayo Clinic, Rochester, Minnesota. I have no relevant disclosures. Although the newest 8th edition of lung cancer staging now classifies patients with a separate tumor in the same lobe as T3, T4 if on the same side but other lobe, and now incorporates ground glass opacity classification into consideration, survival in patients with synchronous multifocal lung cancer does not appear to correlate with the TNM stage. My partner, Dr. Rob Shen, led the newest classification of multiple synchronous lung cancers, or multifocal lung cancers, by including the classification of nodal disease, time interval between cancers, histologic types, or origin of tumor to separate the tumors as synchronous primaries rather than T3, T4, or even M1A disease. A nice study from the Annals of Thoracic Surgery from Nanjing, China, demonstrated in multivariable analysis the different prognostic factors for overall survival and progression-free survival. They compared the Martinian melimad to traditional TNM in multiple synchronous lung cancers, showing how the Martinian melimad classification actually predicted survival when the TNM did not. Their group also showed that the maximal size of the main tumor, stratified into 3 groups, predicted both overall survival and progression-free survival, as seen on the right. In 2014, our group from Mayo Clinic utilized a diagnostic lineage test based on genomic rearrangements from mate pair sequencing to demonstrate how to distinguish independent primary from metastatic disease in lung cancer. By next-generation DNA sequencing multiple samples from 3 groups. Group A, different areas of the same tumor on the left. Group B, synchronous primary tumors with different histologic subtypes in the middle. And Group C, primary lung cancers with distant metastases to other organs to the far right. They showed how lung tumors predicted to be independent primary tumors based on different histologic subtypes did not share any genomic rearrangements, whereas those with separate organ metastasis all had shared rearrangements. This was a very important finding. Aaron Mansfield from our group further demonstrated the heterogeneity of PD-L1 expression among paired independent lung cancers while continuing to show high levels of agreement in intrapulmonary metastasis. Utilizing the Surcos diagrams of agreement in PD-L1 expression, to the far left we see A, comparison between tumor cells of paired lesions and immune cells for each specimen, B, between tumor cells, blue representing agreement and gray representing heterogeneous expression. The 2 diagrams to the right show agreement by type of lesion. A, paired independent lesions, and B, between paired related lesions. Again, more blue is more homogeneous PD-L1 expression. They emphasize the importance of acquiring separate tissue samples in SMLC separate lesions, which may explain the variable response we see to PD-L1 inhibition, likely due to dynamic and heterogeneous expression of PD-L1 from separate tumors of separate origin. The Shanghai group then eloquently sequenced a unique cohort of multiple synchronous lung cancers to determine the diversity and uniformity of genetic drivers upon identical germline and environmental backgrounds. Although the mutation-specific route cells taken during oncogenesis are stochastic, genetic trajectories may be contained by selection for functional convergence on key signaling pathways. The diagram represents the clonal architecture and mutational landscape of multiple synchronous lung cancers. The image to the right demonstrates interfocal and intrafocal heterogeneity of multiple synchronous lung cancers. Our group has also utilized radionomic analysis to develop computer-aided diagnostic categorization of adenocarcinomas, helping to prioritize multiple lesions within the lung and target therapies based on the probability of invasiveness. Our radionomic data analysis program at Mayo, called CANARY, enables easy analysis of nodules to determine the probability of invasive adenocarcinoma based on pixelated analysis of nodule characteristics, scoring them based on categorization of 9 exemplars that are represented as glyphs. Those nodules with predominantly cool tones are more likely to be benign, and warm tones indicate a higher likelihood of invasive adenocarcinoma within the nodule. The overall read is then categorized into one of 3 categories: good, intermediate, and poor risk for adenocarcinoma. These also have been shown to correlate with survival in separate analyses. We therefore can develop a histologic algorithm for classifying multiple lung cancers, adenocarcinomas, as seen on the left, and an integrated histomolecular algorithm for classifying multiple lung adenocarcinomas as seen on the right. Based on our multidisciplinary review, the different tools in our toolbox are offered based on the likelihood that the patient has other developing nodules, underlying lung function, location, size, and prior interventions. The first case I will present is a 72-year-old woman with a history of pneumonia in 2010. Prior CAT scans revealed multiple bilateral nodules and ground glass opacities that were observed. In February of 2015, she underwent bronchoscopy and mediastinoscopy, and the mediastinal lymph nodes were negative. Transbronchial biopsy of the right upper lobe was negative. In September of 2015, she came to Mayo Clinic for a second opinion. She was a 15-pack year smoker, quitting 30 years prior, had a sister with stage 4 lung cancer resistant to treatment with Tarceva as second-line therapy, and was now on hospice. Her pulmonary function test included an FEV1, which was 96% of predicted, and a DLCO, which was 99% of predicted. The PET scan can be seen to the right, and the lesion in the right upper lobe was FDG avid. As you can see in this delineated series, the patient had multiple different histologic classifications of the multiple different lymph nodes, of the multiple different synchronous primary lung cancers that were identified on the image with canary. When looking at nodule number 1 in the right upper lobe, the predicted probability of this being an invasive adenocarcinoma was very high, and therefore it was scored as a poor risk. This typically will require surgery or resection. The nodule measured 3.2 centimeters in size. The second lesion was in the left upper lobe and measured 12 millimeters and had a good risk category. The third lesion had mostly cool tones, was also good risk, and was easily seen on the periphery of the right lateral aspect of the upper lobe, measuring 1.2 centimeters. The fourth lesion also had good risk and was seen on the lateral aspect of the left lower lobe, as circled and measured at 1 centimeter. The fifth lesion was in the central portion near the basilar branches of the left lower lobe, and in fact had a higher risk, intermediate risk group, due to the warmer tones that are seen on the glyph, and it measured 16 millimeters. The canary analysis of the sixth lesion was in the good risk category and is seen in the upper lobe lower below the other one that was seen in the right upper lobe. This one is more anterior. And this one measured 1.2 centimeters in size. The seventh lesion was seen just below that, deeper in the lung parenchyma, and also was categorized as good. Typically, those lesions categorized as good do not warrant as aggressive intervention as those categorized as poor. This one measured 1.2 centimeters in maximum dimension. The summary of the analysis of each of the nodules as represented by glyphs and the glyphs placed on the scout film to represent their locations is seen. The scans are multiple and the dates are in the column to the left with the series number, nodule number, image number, volume assessment, and risk to the right. Bronchoscopy on this patient was normal. Endobronchial ultrasound guided evaluation showed no cancer in the mediastinal lymph nodes. The brain MRI was negative. Our group has published previously that patients with multifocal lung cancer have a 6% chance of brain metastasis when they have multifocal lung cancer, even when it's not suspicious. We proceeded to a video-assisted thoracoscopic right upper lobe anterior and apical segmentectomy, as seen in the segments splayed of the right upper lobe apart from one another. We also performed a right middle lobe wedge resection of one of the other lesions that was localized. The surgery, performed in September of 2015, showed all nodes negative. The methylene blue dye marker localization can be seen on the pathologic specimen of the wedge resection in the right middle lobe. The VATS right upper lobe bisegmentectomy demonstrated a 4.2 centimeter right upper lobe invasive adenocarcinoma, negative margins, lipidic predominant. The VATS right middle lobe wedge resection was a 1.5 centimeter adenocarcinoma, as well as a 0.5 centimeter microinvasive adenocarcinoma. Driver mutations were identified: EGFR mutation of a codon, GLY719, exon 18, and BRAF status was wild type, KRAS status was wild type, and RET FISH TS was negative. In the lesion to the left and the left lower lobe, more laterally located, measuring 1 centimeter in size, a CT-guided biopsy was performed, which was confirming adenocarcinoma. We had many tools in our toolbox and presented the patient to the multidisciplinary thoracic tumor board as well as the lung ablation board. The patient was evaluated by medical oncology, who did not feel that erlotinib was the best next step. We also talked about observation. Given that the lesion was greater than 4 centimeters in the right upper lobe, we discussed but did not decide to offer her adjuvant chemotherapy. Other options were available to her, and they were discussed. We then decided to intervene with a trial that was ongoing at the time called the IMPRESS trial, which was a microwave ablation trial. It employed patients all enrolled and offered microwave ablation percutaneously, followed by surgical resection of the ablated lesion. CT-guided percutaneous microwave ablation of the left lower lobe 1 centimeter lateral lesion was performed, followed by VATS wedge resection. The mediastinal lymph node dissection again was negative. The surgical pathology of the left lower lobe thermally fixed nodule, because it had been ablated, was microinvasive adenocarcinoma 0.8 centimeters and was negative margins. This shows what the lesion looked like after microwave ablation when we performed the wedge resection. You can see the surface of the lung was also burned for the microwave ablation, and the lesion was completely removed with negative margins. The imprint, ablate, and resect study, allowing for patients to have resection of an ablated lesion, was performed after computer-aided guided microwave ablation to measure and plan the wattage and energy, as well as the time and duration of ablation from percutaneous approach. This is the picture of the system that was utilized in the bottom left of the screen. We then had the intermediate lesion that was seen in the left lower lobe central region. Because of concerns from review and increase in size, we felt that this lesion needed to be treated. After a long discussion with the patient and the multiple discipline team, we decided to offer this patient stereotactic body radiation therapy. This is for the 2.3 centimeter left lower lobe lesion, due to the fact that we were concerned that a basilar resection would be very difficult because the patient had already undergone a wedge resection of the left lower lobe. The patient would virtually have to undergo a complete left lower lobectomy because of the hilar location of the tumor. We were attempting to try to spare the patient some lung function. This is the radiation treatment planning as seen on the image to the right. The IMRT treatment planning images can easily be seen as the patient's focus of treatment was at the central area of the ground glass and solid components of the tumor, making an effort to spare the esophagus, aorta, heart, and spine. The patient had some minimal progression in the right lower lobe. We elected to observe. Eventually, as some of the other lesions started to grow, we elected to start the patient on erlotinib. We gave adjuvant chemotherapy, sublobar resection, SBRT, CT-guided ablation as all possible options for treatment, but ultimately the patient elected to start on erlotinib. As you can see, as we span through the chest, multiple other lesions can be seen within the lung. The radiated tumor in the left lower lobe can also be seen, and continuing as we scroll through the entire chest, multiple other lesions can be seen throughout the lung. SBRT to the right lower lobe was then employed in 2019 for the lesion that appeared to progress. Progression was noted at only this lesion. All other sites of disease remained stable. This shows the summary of treatment of each of the nodules that were employed for the patient. As each nodule was identified, those that were treated surgically have a scalpel with a circle pointing to the lesions at the glyph. Those that were treated with erlotinib have the RX, and those lesions that were treated with IMRT or SBRT are seen with the radiation symbol. Those lesions that were treated with ablation have the ablation symbol, and then the ablate resect is seen and the ablate pointing to the scalpel. Case number 2. This patient also had canary analysis with multifocal lung cancer. He had multiple family members that had lung cancer and had a dominant lesion in S10 segment of the right lower lobe. The 3D image of the lesion in the right lower lobe, measuring at least 2 centimeters in size, is easily identified on the 3D image rotating and in the reconstruction image to the right. This case is published in the Journal of Thoracic Disease along with surgical video. We can see just the tracheobronchial tree with the lesion to help us identify which segment the tumor arose from. This was a video-assisted thoracoscopic S10 segmentectomy. The patient had the approach from the VATS right side. The 3D image of the anatomy helped us to delineate which branches of the pulmonary artery would need to be ligated to acquire adequate pinpoint visualization of the intersegmental plane. Initially, when we started to encircle and staple and divide one of the pulmonary artery branches, we decided that we would infuse ICG and follow with pinpoint visualization. At this point, we determined that we had incorrectly encircled the wrong branch of the pulmonary artery. Because we had located the tumor with methylene blue dye marker injection prior to performing the surgery, we could see that the segment surrounding the tumor turned green. If we had correctly ligated the right artery, then the segment surrounding the tumor would have stayed pink and not been illuminated with green. Here, we have now ligated just by encircling and not dividing with a vessel loop the correct pulmonary artery. By showing in this video the optimal pulmonary artery being blocked, we were able to show that no ICG went to that segment and all of the other segments were illuminated. By making sure that the methylene blue dye marker segment remained dark without illumination with ICG, we were sure that we had isolated the correct artery. Here you can see the intersegmental plane is clearly delineated and marked with a marker. This allows us to know exactly where we need to staple. By using the ICG multiple times, injecting 3 to 6 cc's IV followed by 10 cc's IV push, we can see the exact intersegmental plane and then staple exactly where we need to. It's important to know for the S10 segment, you have to divide some of the anterior right lower lobe to be able to reach the hilum and properly perform the stapling. This patient subsequently presented with nodal progression at a later time from multifocal lung cancer from some of his other tumors. Currently, that patient has undergone genetic analysis and has an EGFR gene, which is identified to be a mutation for both 2 separate parts of the EGFR gene. 35% of lung adenocarcinoma patients have a somatic mutation in the EGFR gene. EGFR mutations, primarily those occurring in the tyrosine kinase domain, exons 18 through 21, result in constitutive activation of the RAS-MAPK signaling pathway. Current data suggests that the efficacy of EGFR-targeted therapies in patients with non-small cell lung cancer is limited to tumors with activating mutations in the EGFR gene. The EGFR T790 mutation identified in this patient is associated with acquired resistance to tyrosine kinase inhibitor TKI therapy in about 60% of patients, with disease progression after initial response to erlotinib, gefitinib, or afatinib. Recent data suggests patients with metastatic lung cancer and the T790 mutation may benefit from Tagrisso or osimertinib, an FDA-approved TKI that inhibits the T790 mutation and other EGFR activating mutations. Thus, the detection of the T790 mutation within this tumor suggests that this patient may benefit from treatment with Tagrisso or osimertinib. TKIs bind to the tyrosine kinase domain and the epidermal growth factor receptor and stop the activity of EGFR. Monoclonal antibodies such as cetuximab or nasitinimab bind to the extracellular component of the EGFR and prevent epidermal growth factor from binding to its own receptor, therefore preventing cell division. This case had a nice response to treatment, as you can see before treatment on the left and after treatment on the right. We are currently considering surgery for this patient. The summary of his treatment is delineated below. He has multiple other lesions throughout the lung that we will be continuing to monitor. Our final message and pearls of wisdom include that multifocal lung cancer requires a strategic lung-sparing approach. It is controversial because there are rarely standards of care in this patient population. Options include parenchymal sparing surgery when possible, lung ablation, radiation, and systemic therapy, as well as immunotherapy. Patients should have multiple lesions evaluated, as tumors can be heterogeneous. Considering patients urgently for a genetic analysis to identify driver mutations with the option of targeted therapy is sometimes the best course of action when localized therapy is no longer an option. Thank you for your attention. I hope that you found this helpful, and we remain available for questions. It's been our honor to present to you.